Hello everyone. Today we'll be talking about fever. So fever is basically elevation of body temperature, right? Body temperature is controlled by thermoregulatory center of the hypothalamus. Fever is an elevation of body temperature that exceeds the normal daily variation and occurs in conjunction with an increase in hypothalamic set point. What you need to understand is our body temperature changes from day to night. It is in constant variation. And the hypothalamic thermoregulatory center, it gives or it provides a set point for body temperature. The blood that is constantly bathing the thermoregulatory center is at certain set point, and when in illnesses the thermoregulatory center changes its set point, so the blood bathing the thermoregulatory center should also change its temperature. And it does. Our body changes our body temperature by various processes such as vasoconstriction in the periphery. It changes temperature by chills, by rigors and all. So definition of fever. Fever is said to happen when the oral temperature at 6 am is increased more than 37.2 degrees Celsius, and at 4 pm the body temperature increases beyond 37.7 degrees Celsius. You can see there is change in 1 degree Fahrenheit variation, right? 98.9 Fahrenheit in morning and 99.9 Fahrenheit in the evening. So there is 1 degree Celsius variation in our daily temperature, and increase beyond these temperature is said to be fever. So rectal temperature is generally 0.4 degrees Celsius higher than oral temperature, and in menstruating women, AM temperature, morning temperature is generally low 2 weeks before ovulation, and it rises by 1 Fahrenheit after ovulation till menses. Hyperpyrexia is a fever that is beyond 41.5 degrees Celsius or 106.7 degree Fahrenheit. Fever versus hyperthermia. In fever, as I already said, there is increase in the hypothalamic set point, but in hyperpyrexia, in hyperthermia there is no increase in hypothalamic set point, i.e. hypothalamic set point is unchanged. Fever responds to antipyretics. Why? Because it depends on pyrogens, but hyperthermia does not respond to antipyretics. Now let's talk about pathogenesis of fever. Before understanding these pathogens, we need to know what is pyrogens, right? Pyrogens are molecules or different things that cause fever. Abnormal conditions such as infection, microbial toxins that might be either endotoxin or enterotoxins, mediators of inflammation and other immune responses. These changes or these modifies monocytes and endothelial cells. Now these monocytes and endothelial cell, it produces pyrogenic cytokines. By name suggests pyrogenic, meaning these cytokines, it results in fever. Now these pyrogenic cytokines, it activates hypothalamic endothelium to produce a very essential thing, that is PGE2, prostaglandin E2. Now this prostaglandin E2, furthermore, it potentiates the production of cyclic AMP from glial cells in the brain. Cyclic AMP is a neurotransmitter. Now this neurotransmitter actually elevates the thermoregulatory set point. Due to this, there is heat production and heat conservation that finally leads to elevated body temperature, that is fever. Now what you need to know is microbial toxins sometimes can directly affect the hypothalamic or brain endothelium. That is, the toll-like receptors in the hypothalamic endothelium may recognize microbial toxins and may potentiate the production of PGE2 and cyclic AMP. Also, various events such as various conditions such as non-specific myalgias and arthralgias are in association with fever. Why? Because the pyrogenic cytokines in periphery potentiates increase in PGE2 that results to non-specific myalgias and arthralgias. Types of fever. There are three types of fever, that is intermittent. One is intermittent, second is remittent, and third is continuous. Intermittent is this presents for several hours and it finally touches baseline. This is very important, touches baseline. Remittent, what happens is there is fluctuation but it does not touch baseline. That means it never falls to normal body temperature. Now continuous is it does not fluctuate more than 1 degree Celsius and it never touches baseline. There is a continuous fever. Various conditions associated with these different types of fever is intermittent fever might be quotidian, that is daily, related with abscess, sepsis and UTI. Torsion, that occurs in alternate days with Plasmodium vivax and Plasmodium falciparum. Quercein, 2 days, that is associated with Plasmodium malaria. Remittent is associated with amoebic liver abscess and septicemia. Continuous is associated with lobar pneumonia and meningitis and rheumatic fever. Whenever you listen to rheumatic fever, you need to always understand that it is a continuous type of fever. Various causes of fever, that might be infections, malignancies, autoimmune conditions and others. Infections might be bacterial, viral, parasitic, fungal. Malignancies such as leukemia, lymphoma, hepatoma and nephroblastoma. Autoimmune conditions such as rheumatic fever, rheumatoid arthritis, vasculitis and others such as drug-induced fever and factitious fever. Now treatment. Treatment is fever is actually a symptom, or fever is actually a condition that is associated with other causes, right? So we either treat the cause and we prevent the fever. Treatment of fever and its symptom with routine antibiotics does no harm. There is just what happens is we treating the fever and its symptoms with antibiotics does no harm and does not slow the resolution of common viral and bacterial infections, meaning we can use according to our need, right? However, in certain bacterial conditions, withholding antibiotics helps us evaluate the effect of certain antibiotics. The evaluation of antibiotics by preventing the use of antibiotics. Also, if we hold antibiotics in certain cases, then we may come across diagnosis of some unusual febrile illness. Now, mechanism of antibiotics. How antibiotics helps in reducing fever? As we already know from the pathogenesis, the very important thing in fever is PgE2 level, right? So if we reduce PgE2 level in thermoregulatory center, then we can reduce fever. PgE2 is formed from arachidonic acid by the action of cyclooxygenase enzyme. So if we inhibit cyclooxygenase enzyme, then PgE2 level will decrease. Hence, antibiotic potency of drugs is related with the inhibition of brain cyclooxygenase. Certain drugs, antibiotic drugs such as acetaminophen, is actually a low antibiotic in the periphery, but it can enter into the CNS, gets oxidized by P40 enzyme and finally inhibits COX-3. COX-3 is only found inside CNS. Oral aspirin and acetaminophen are equally effective in reducing fever in humans. NSAIDs such as ibuprofen and specific inhibitors of COX-2 also helps in preventing fever. Now we know glucocorticoids are also an effective antibiotic, but it works by two mechanisms. Firstly, it inhibits phospholipase A2. Phospholipase A2 is an enzyme that is required to release arachidonic acid from cell membrane. Secondly, glucocorticoids also blocks the transcription of mRNA that are essential for production of pyogenic cytokines from various macrophages and all. Now, fever of very unknown origin. What happens is fever occurs with viral and bacterial infections and gets subsidized, gets eradicated in certain days. It is self-limiting, we can say. But fever that is greater than 1 degree Fahrenheit and it lasts for the duration of longer than 3 weeks without any immediate diagnosis, then we can say it is fever of unknown origin. Clinicians basically, without an initial diagnosis, refer any febrile illness as a fever of unknown origin up to the point the diagnosis is made. So, conditions of declaring a fever of unknown origins are fever greater than 101 degrees Celsius at least 2 occasions, illness duration greater than 3 weeks, and there is no immunocompromised state. Also, the diagnosis that remains uncertain after a thorough history taking by physical examinations and obligatory investigations. If we don't come up with a diagnosis, then that fever is fever of unknown origin. So, approach to patient of fever. How do you approach to the patient of fever? Firstly, physical examination. What we do is, in physical examination, we give importance to the chronology of events that preceded fever, such as travel history taking, exposure to infected patients, etc. Also, we measure temperatures through various locations such as oral, axillary, rectal, esophageal, and tympanic membrane. We need to be cautious while taking physical examinations in case of newborns, elderly patient with chronic hepatic renal failure, and patient taking glucocorticoids or being treated with an anti-cytokine, because they may have active infection in absence of fever because of blunted febrile response. Even the absence of fever, they may have an active infection in these patients. Now, the laboratory tests includes complete blood counts such as hemoglobin count, TLC, DLC, platelet count, measurement of cytokines such as interleukin 1 and TNF. These are the pyrogenic cytokines, and C-reactive protein levels and erythrocyte sedimentation rates. This is also very important investigation. Fever in patients who are receiving anti-cytokine therapy. We know in the patients receiving anti-cytokine therapy, the febrile state is highly subsidized, meaning patients with long-term treatment with anti-cytokine based regimens are at increased risk of infection because of lowered host defenses, right? So they are at increased risk of infection because of lowered host defenses. The disease, such disease or the treatment for disease like Crohn's disease, rheumatoid arthritis, and psoriasis comes under this therapy. The febrile response is blunted in such patients, so even low-grade fever must be dealt with rigorous and early diagnostic evaluation, because even low-grade fever may be associated with very heavy infection. Thank you.